Hi, everyone. Thank you so much for joining us today here at Mingle Health. Our webinar topic today is Succeeding with MIPS in 2021. Whether you're getting started or looking to start to finalize your submission, it's quarter 4, and now is the time to make sure you've got everything in place to avoid a penalty and maximize your participation. If you're new here, we'd like to say a big warm hello and welcome. I'm Charles Howes, the head of marketing here at the organization. We've been in business since 2012 as a qualified registry and what we like to say as a trusted partner. We focus on helping you improve what matters, guiding you every step of the way in the transition to value-based healthcare. We're trusted by more than 75,000 clinicians since 2012. And we believe in what you see here, this cycle. It has lots of different names. But in general, it's the idea of what you measure gets improved. And this process and cycle that we support our clients through really makes meaning of the work that you're doing participating in MIPS and these quality programs to look at your performance, analyze opportunities for improvement, inform those priorities within your practice, and then see what changes you can make happen within a year, within a quarter, within a month, in your care teams and with your patients. Some logistics for today before we get started. This session is being recorded. You can download the slides from the chat. There's a link there. And after our session, we're going to email out the slides and the recording. We do hope that this is interactive. So throughout the session, we encourage you to ask questions. We have saved plenty of time at the end to answer as many as we can. And so take this opportunity to talk to our expert who we have. That brings me to our presenter. Today, I'm joined by my colleague, Brigid Whitney Gallagher. She's the manager of client services here at Mingle Health. And she is one of our earliest team members who has helped hundreds of providers succeed with these value-based care programs. In her role here at Mingle, she's responsible for not only training folks on program changes, but she also manages a team of quality program consultants. And these are the people that when you work with Mingle, you get assigned a dedicated support specialist, expert, consultant, as we fondly refer to them internally, to guide you through this program. So when you work with Mingle, you're not just buying some technology and getting a login. You have a dedicated person who's going to guide you through all the steps to be successful with the program. So with that, Brigid, why don't you take us away?
Thank you, Charles. Hi, everyone. Welcome to the webinar today. I'm so glad that you are joining us. I'll just review the agenda. We're going to kind of decide what's at stake. Basically, why are we doing this? What's there to gain, what you might stand to lose. As Charles mentioned, we have plenty of time at the end for question and answers. There's so much variation in the program that sometimes it's just helpful to give your specific situation and see if we can figure out what's going on. I also really am going to spend some time talking about how to be successful. And success can mean a lot of different things, again, depending on your practice priorities. So we'll be discussing that. We have a few polls that we're going to do today. I think Charles is going to kick one off right now. So take a few minutes to answer the poll. The purpose of the polls, as they're scattered through, is to really help this be interactive and to make sure that I'm providing information that is helpful for all. So go ahead and look at that poll, make a few selections, and then we'll move forward.
Yeah, we're excited to dive in here, Brigid. And I do like that you pointed out that success is different for everyone. That's definitely key with these programs, depending on your organization, specialty, priorities. how the pandemic is
Absolutely.
impacting you.
Yeah,
All
one
right,
thing
so
that,
we've got a lot of responses here. We'll just take
great,
5 more seconds, and then we've got one quick additional poll, and then we'll get on with the content.
great.
All right, well, just for all of us to see quickly, this is super helpful to help us understand what brings you all here today. Understanding MIPS requirements, that's key. They change every year. There's new proposals every year. We're awaiting the final rule in a month or so. And also how to improve your scores. That's great to hear. And QPP trends. So some good topics that we definitely plan to cover. And just finally here, give us an idea of your role in your organization. Um, don't answer if one doesn't fit, but also feel free to just put the closest fit that that's you. And we'll do about 10 more seconds. Thank you, everyone. All right, and just to share that back so we all take a look, we've got a whole mix of stakeholders. Not surprising that practice managers, administrators, office managers are at the top there. But this really helps, the fact that we've got all kinds of different roles represented here, it speaks to what it takes to be successful in this program. So we're going to touch on that throughout. All right, back to you, Brigid.
Great. Thank you, Charles. All right, let's jump into it. What are we doing here? We are talking about the Quality Payment Program. And the Quality Payment Program, or QPP, has two pathways. One pathway is the APM, or alternative payment models. You also might hear advanced APM. That's another term that's thrown around associated with that first pathway. Where we are focusing today is the MIPS program, the Merit-Based Incentive Payment System. And that's the program that we're going to dive into. That's the program that Mingle Health has spent a lot of time working towards. We also are developing expertise in the APM systems as well. But today we're going to look at that second pathway, the MIPS program. The MIPS system, the merit-based incentive payment system, scoring divides down as you see on the slide. There are 4 different categories, and the categories hold different weights and are worth more or less. Again, I'm just kind of going to caveat this whole thing. The information here is kind of general. This is the standard. There are all kinds of reasons and opportunities to shift those category weights around, and we'll talk about that later on in the presentation. All right, this is the infamous "you are here." When we think about MIPS reporting, we really are looking at about a 15-month project. The reason being is that we know it takes a huge amount of time to do all the different pieces that are involved. The measurement period, or the program year, starts on January 1st and ends on December 31st. And then we have the first quarter of the next year to put all that information together and submit to CMS. The program has shifted over the years. You can see on this graph, what we've really seen is some adjustments in the way the different categories are emphasized. You can see that in year 1, quality was 60% of your score and cost was 10%. By legislation, starting in the year 2022, so coming right up, cost and quality have to both be worth 30% of your score. That has been written into the MIPS legislation since the program started. Now, the kind of asterisk on all of that is that We know that with the pandemic, with the public health emergency, and with some other market factors, we have seen CMS change some of these. For example, last year, by last year, I mean 2020 submission, the quality category was slated to be at 45%, and it ended up being higher because CMS reweighted the entire cost category. So we have seen changes like that, but in general, this is where we're heading. Oops, excuse me, I have some graphics coming up here. The 4 different categories that we've talked about are quality, cost, improvement activity, and promoting interoperability. We'll just run through them a little bit. So quality for 2021 reporting is worth 40 points. It requires a full year of data. By that, I mean it requires data representative of billing that has happened throughout the entire calendar year. Has to include all payers, and you have to report on at least 70% of your eligible patients. The cost category is worth 20 points. Again, it's a full year of data. This category is calculated by CMS. And so there isn't anything that you specifically need to submit. In essence, you're already reporting this category as you bill CMS throughout the year for services rendered. They do calculations based on the way you're submitting claims. We have the improvement activity category, which is worth 15 points. This is at least a 90-day reporting time frame. There are some specific activities that require 6 months or a full year participation, but the minimum is 90 days. And then promoting interoperability, which is kind of a rework of what used to be meaningful use, is worth 25 points. And again, that has to be at least 90 days. Something just to call out around improvement activities and promoting interoperability, although they do have to be 90 days, it does not necessarily have to be a specific quarter. And so that allows a lot of flexibility in finding timeframes where you're scoring well, finding timeframes where you might have different providers participating in different improvement activities, etc. Okay, let's talk about what's at stake. This is kind of where the rubber meets the road. So a couple things I want to highlight here. One is the penalty range. So the penalty range is a static number. By that I mean it is what it is. It's not changing. We know that for a practice that does not participate in the MIPS program, if they are required to participate and they do not, they will receive a negative 9% against all of their reimbursements in the payment year. What is flexible, and I'm going to kind of explain that in a little bit more detail, is what this incentive is, and here's why. The MIPS program, the entire QPP program, is budget neutral. Meaning that it's not tied to any particular government funding, or it kind of takes some of the politics out of it. Any dollars that are collected in penalty are redistributed in incentive. That means that we are only going to see negative 9% and positive 9% if the same amount of dollars are collected in penalty as are distributed in incentive. What we are seeing practically is that we have less people being penalized than we do earning an incentive. And so what we've seen in prior years is that that penalty is static. We're looking at a 4%, 5%, 7%, 9% penalty, but that incentive range has been as low as 1%, 2%, 3%, given the additional opportunities to avoid penalty because of the public health emergency. For 2020 reporting, we are seeing a max incentive of around 2%, just under 2%. So we have 9% here. That's the idea. That's the budget neutrality. But when it comes down to, what's actually going to be showing up in your bank account, we're looking at a much lower number. So I understand that can feel a little discouraging, but here's the thing. We know that that 9% is here to stay. The other piece of the puzzle is illustrated on this next slide. What you need to avoid the penalty. Now, in this performance year of 2021, so this calendar year that we're in, a practice has to earn 60 points to avoid the penalty. Moving into next year, into 2022 reporting, it's 75 points. We know that sometimes just hitting that 60-point mark can be incredibly challenging. 75 points can be very challenging. There are so many factors at play: systems in your practice, specialties, provider credentials, all kinds of things come into play that can make MIPS reporting inherently harder or easier. What I kind of want to highlight is that as the program gets more challenging, there will be more dollars collected in penalty, which means there are more dollars to be distributed in incentive. Moving forward, earning an incentive in the MIPS program, even avoiding a penalty, is going to require more effort. So we're going to need investment, we're going to need focus, we're going to need lots of pieces to come together to get folks up over that penalty avoidance threshold. And we know not everybody's going to make it. That's okay too. Let's talk about what it means to be successful. Well, looking at 2021, we are in October, the middle of October in 2021. We need to be kind of realistic about what the goals are here. If you are brand new to MIPS or brand new to reporting, haven't ever kind of worked in this area before, my recommendation to you is that we try to avoid a penalty for 2021 and we hit the ground running for 2022. The submission deadline for 2021 data is March 31st. That should actually be March 31st, 2022. Sorry about that typo. We don't have a huge amount of time between now and then to do all the different pieces that would be required to have a really robust, high-scoring submission. That being said, avoiding a penalty, moving through and saying, okay, we're going to avoid a penalty this year. What are we going to do next year? How are we going to make this happen? A couple other really important pieces of a successful MIPS participation. We have to understand clinicians' eligibility. Make sure that you're hitting deadlines for those two categories that require 90% performance periods. For lots of folks, these are probably things that are happening year round, and it might just be a matter of identifying what 90 days you want to report on. However, it's always important to make sure that you're being intentional and moving forward with that. We want to understand any year-to-date performance, which is part of why we want to get quality going early. And we want to also understand how you've performed in the past and what impact that could have on the future. And then we got to talk about those exemption deadlines. We're going to get into those in detail. Okay, let's talk about setting goals for your organization. There are a lot of things that are kind of important when you think about the goal. The first thing is that this needs to be the goal of your organization, not just necessarily the goal of the person doing the work. Here's why. When MIPS was earlier in the MIPS program, and also in the early days of PQRS or value-based purchasing, some of these other quality programs that CMS has had, the bar starts pretty low. When MIPS started, you just had to get 3 points. Literally, you could report on any single patient for any single measure one time and avoid the penalty. That's not where we are anymore. So at this point, you really do need to think about What sort of investment can your organization make? Can you meet with a consultant once a quarter, once a month? Do you have the resources that it takes to generate the data that's required for the program? Can we piggyback and use work that you're doing for other programs, for Million Hearts campaigns or some of the quality programs for your private insurers? We also really need to think about what are we trying to get out of this? Some practices can look at programs like MIPS and use them as a springboard or practice transformation or participation in an APM or different other types of credentialing. Sometimes I'm going to say often, practices are doing the best they can just to take care of their patients. And so sometimes the goal of reporting MIPS is to avoid the penalty and have it be as low stress and low resource as possible. We can absolutely help you with that too. Our consultants really can meet you where you're at, whether that's, we're using this program as a springboard to transform healthcare, or oh my gosh, I just got to get this check in a box so I can get back to scheduling my patients or running my office or whatever it is. Wherever you are, we're ready to help you. Knowing where you are and what you want out of the program is the first step to getting a successful submission or successful participation. Let's talk about the QPP website. So CMS has set up this really well done, informative website, qpp.cms.gov. They have a resource library. They have a whole bunch of really good information out there. One of the best pieces of this is the QPP participation status. This is their lookup tool. You put in your NPI number, your provider's NPI number, and CMS tells you what they are required to do related to the MIPS program. You might find out that your provider isn't required to make a report this year. Great. You might find out that your provider is required to report, or they're required to report, but they have a different status, and so they have to report through a different program. A lot of information here. One thing I just want to call out here is that what you find in the QPP lookup tool is CMS's official record. This is how they're going to score you. It may be incorrect, right? It may be wires got crossed, errors happen. If you do see a status there that you believe to be incorrect, let us know. We can certainly help you. We can help you interface with CMS. The other thing to point out is that that is how CMS is going to score you, whether you think it's correct or not. At the time of lookup, that's how they're going to be scoring your providers. So it's really important to know what you're being scored against. For those of you that haven't worked with Mingle Health, our user interface pulls all this information from CMS directly over into our interface. So these are conversations that you would have with your consultant going forward. One of the things that gets really tricky, and one of the reasons I recommend that you have a consultant in your corner, is because understanding your clinician's eligibility isn't as simple as do they need to report MIPS or not. Certainly part of it, but there are all kinds of caveats and variations and all kinds of opportunities to have things be a little bit different in your case. We have special statuses which change the weight of different categories in the MIPS program. Some special statuses remove the PI category altogether. Some statuses double points or award bonus points. All of that's important to understand. The other thing I just want to call out before we move on is that the determination periods, the MIPS determination periods here in purple, are the timeframes that CMS looks at the claims that your providers are involved in, that your providers are submitting for remittance. And those are the claims within those timeframes that your providers are being judged against for things like special status, low volume threshold, MIPS eligibility, QP statuses, facility-based statuses, other things like that. They don't, CMS doesn't usually publish the results from the second determination period, which has just closed this past September, until November. Last year it was later because of the pandemic. So I just want to call out that this is another good plug for consultants. These statuses change. They change throughout the year. You can have statuses and lose them. You can gain statuses that change your scoring. It's really important that you have a process or a system in place to make sure that your eligibility is being monitored. And that's part of what the Mingle Health interface does. We monitor that. I say we have computers that monitor it. And then we have consultants who talk to you about what's found, changes in eligibility, changes in scoring, things like that. So plug for consultants there. They really can help make sense of what can be a very complex topic. All right, let's talk about improvement activities. Improvement activities require a minimum of 90 days. So hopefully you already know what your improvement activities are. The last day you could have successfully started an improvement activity for 2021 reporting was October 3rd. A couple things to call out. Improvement activities can seem really simple. It's a simple attestation. You're simply saying, yep, I do this activity. These are probably things that your practice, at least in most cases, do already. Things like participating in other quality programs, having stewardship programs, having structured staff training, structured practice improvement. So there are lots of good places to start with work you've already done. One thing I do want to be really clear about, though, is that the data validation criteria, which is basically CMS giving practices information about what's required in a specific activity, changes from year to year, and it is very specific. So I would recommend that you work with a consultant, talk about the things your practice is already doing, and review that data validation criteria very closely to make sure that you are doing everything that's required of the activity. There are, we had a couple of cases where, because the requirements changed from year to year, a practice thought they could do the same activity, but at the last minute had to do something else. That can be very stressful. So make sure you're reviewing that very closely. Also, for those of you doing group reporting, at least 50% of your clinicians have to participate in the activity during your time frame. So that's just another kind of complication, or it could be a complication if you don't have a plan in place and aren't confident in your improvement activities. In the PI category, or promoting interoperability category, we have one new measure. It is HIE alternative, second up from the bottom there. It is asking about bidirectional exchange. It's a yes or no response. It can be reported in place of the health information exchange, which are the two measures up above. For reporting PI in 2021, you have to have a 2015 cert. If you go to the Chapel website, you can look up your EHR system and see if it does have that 2015 cert. October 3rd was the last day that your 90-day performance period could begin. So you're already in your opportunity for that 90-day performance period. Also, a group being hospital-based, that's been tweaked a little bit this year. So if you have been considered hospital-based and are not subject to the PI category in years past, you might be subject this year. So again, another plug for eligibility. Make sure that you are checking that. We have a great promoting interoperability guide that's available here for download. I recommend all of you take a peek at it. It kind of goes into some really good detail about things that have changed and how to make the most out of the category. All right, let's talk about the quality category. The quality category is worth the most amount of points, so it gets a lot of attention. This is a screenshot from our Mingle interface, and this is kind of hitting all the really important points. We are identifying the different measures. Measure selection is a really important piece of reporting quality. Choosing measures where you have patients that are eligible, but not too many, where you have measures that you know your providers are interested in doing, measures that maybe are part of other programs, so you know they're already being focused on, measures that are straightforward or measures that are related to your specialty. Selecting these measures is really the first step to having a solid quality score. The next step is really understanding what's happening in your practice as far as the data is concerned. One of the reasons that we really recommend turning this into, a year-long project is that if we can catch, let's say, a documentation gap in Q1, you can remove the gap, right? Fill the gap, whether it's training or maybe a dashboard tweak in your EHR, and then the entire rest of the year you're already doing what you need to capture that A1C or that flu vaccine or whatever it is. If we wait till the end of the year, you're having to go back, maybe do a lot of chart abstractions, go back and look at a whole year's worth of patient records. That's really stressful and can be time consuming. And so the sooner we get started understanding what your data is showing us, the better opportunity we have to improve that data. I'm going to talk about that probably for the next 5 slides because it is really important. In our dashboard, we show you the estimated points that you would earn, both performance points and any bonus points that might be subject, that your practice might be subject to. So you kind of have an idea of where you stand at the moment. And then, of course, when we're ready to help you with that submission, we go through the entire process and make sure that the final numbers are where you need to be. I want to talk just a little bit about measure score changes. Here's why. If you do the exact same year over year, you will not get the exact same score. In our, we have this great report that you can see here in green that kind of shows if you did exactly the same as you did last year and it was scored against this year's benchmarks, here's what you would score. Measures go up and down. We have new measures coming in. We have measures that become topped out. So even though you could earn 10 points, now you can only earn 7 points. We have measures that lose their benchmark. We have measures that gain benchmarks. There are all kinds of reasons why measure scores change. And doing the same performance year over year is not going to get you the same result. That's another reason that I say start early with your data, so we can be clear about what you're working towards kind of from day one, where you need to do better on a measure, where you need to maybe select a different measure. The sooner we have that information, the sooner we have a plan, the better opportunity for the highest score. Okay, let's talk about your feedback report. So your feedback report is a CMS report that is available to anybody who reported MIPS through the qpp.cms.gov website. It's basically CMS's report card for you. This is how CMS has judged you in the past, how they've scored your practice in the past. Right now we're looking at 2020 final score. That's the example we have on the screen. CMS breaks down how they scored you in each of the different categories. You can see in this case, promoting interoperability didn't apply to this practice. So you see the NA there and the points were weighted to other categories. This details out your payment adjustment, what CMS is anticipating you will receive, either an incentive or penalty moving forward. This is also the best way to understand how the cost category applies to you and your practice. CMS doesn't give cost information in real time. So there's no information provided to you by CMS about how you're doing in the cost category for 2021 reporting. The best that we can do is look at how CMS has scored you in cost in the past, and then see if we think those trends will continue into the future. The information available around the cost category is pretty impressive. Just if I can be a data geek for a minute, they break down all kinds of different metrics, looking at patients, patient attribution, different sources of care from your patients that may or may not be assigned to you, all kinds of really crazy nitty gritty things. So accessing this feedback report is incredible. And again, I'm going to plug consultants and tell you that looking at this feedback report, I would say maybe 30 to 40% of the information is readily available, particularly when you get down into the crazy cost, different sub-reports. It gets a little overwhelming, and a consultant can really look at that with you and help you understand what you're looking at, what it means, and what you might be able to do differently to impact the way that CMS scores you moving forward. All right, so this is our project plan. We basically follow the steps. We've been doing quality reporting for years. This is kind of how we do it. For those of you that haven't ever worked with a Mingle before, it starts with kickoff and planning. We want to know what's important to you. What are you working towards? And then we move into the quality management. That's when we're going back and forth with data, reviewing reports out of your EHR, making sure that your documentation is where it needs to be, helping you understand any gaps that might be going on. And then we prepare your submission for CMS, we review it. Part of that preparation is really thinking about how CMS is going to score your submission. One of the things that Mingle Health and your consultant in particular brings to the table is being strategic about the score. Sometimes what is in the best interest as far as a score is concerned of the practice is to not report a particular category, maybe take a hardship. Maybe there's an opportunity to use an EMA cluster or some other CMS provided resource to make the score be where you need it to be. That's a huge part of what your consultant brings to the table. It's being able to strategize and understand the rules of MIPS to the point that they can make recommendations about how to make the program work for you. At the end of the day, we are ready and happy to make that submission to CMS if that's in your best interest, if that's what you decide to do. Making a submission to CMS is the final step for a lot of practices. That being said, if you're not subject to the MIPS program this year, working with us, following a project plan, staying current with the program, staying current with your data resources is still so important. We have seen practices who maybe weren't subject for 2 years, maybe weren't subject for 1 year, but then when they are subject, there's a 60% point threshold and a 9% penalty. That's a really hard place to start if you haven't been paying attention and haven't been engaged with the program for a while. So yes, of course, we help you make that submission to CMS, but even if the submission to CMS isn't part of your plan for whatever reason, we still want to engage with you because the program isn't going away, and in most cases, you will be subject to it at some point. All right, so here's how we can use MIPS and help you use MIPS to really move towards value-based care. So the most important thing is take care of your patients, obviously. That's why people get into medicine. We want to have your patients be as healthy as possible. We want your patients to be satisfied with the care they're receiving at your practice. We want to let your doctors be doctors and do the good care that they do. Do the good patient care that we know that they do. The next part of that is to use your EHR effectively, and here's why. If your doctors are doing amazing care, they're taking really good care of their patients, but it's not being documented, it's like it never happened. What I have found time and time again with lots of different practices on lots of different systems, if somebody scores really terribly in a measure, it's possible that their doctor just isn't doing whatever it is, but most likely in most cases the issue is the way that that patient encounter was documented. So maybe your doctor is checking blood pressure, but it's being entered as part of a note instead of part of a vital. That's gonna really disrupt the way that the rest of, in this case, CMS, but kind of the outside world sees the care that your providers are giving your patients. So using your EHR effectively, making sure that the quality work, the care that your doctors are giving patients is being documented effectively and is being represented appropriately is a really important piece of value-based care. We also want to think about tracking your patient's needs outside of your practice. Here's why. When a patient comes from primary care to a specialist and back to primary care, we're relying on that primary care provider to have all the information the specialist had, right? Obviously, your primary care provider needs to know the basics, new medications, things like that. But also, your primary care doctor wants to understand everything that's going on with that patient so that they can, again, take good care of the patient, right? Provide that quality care to the patient. Tracking your patient's needs outside of your care is key to that. Knowing who your patients are going and seeing is key to that. Who are you referring your patients to? Are you ending up with lots of duplicate tests, for example, that can impact your cost category, that can impact your quality scores, that these impacts that are measured in MIPS all trace back to that quality care of your patient and making sure that the quality care you're giving is being represented, it's being documented. So MIPS is a great springboard to jump into value-based healthcare. It's a great place to start, and you can kind of work backwards into that value-based care success. All right, we're here to help. That's really what we're doing here. We want to partner with you. The goal with our webinar today and the goal that we do with our practices is to partner together and make the MIPS program, make quality reporting be helpful for your practice. Sometimes that means submission, sometimes that means no submission. Sometimes that means digging really deep and getting crazy into workflows or into reports or data resources. Sometimes that means putting the check in the box and getting this off your doctor's plate. Whatever it is, wherever your goals are, this is where we want to be able to connect with you and really meet you where you're at, see what's going on with you. How can we help? I just kind of want to shout out for consultants again. Every consultant here, our goal is to be helpful. And what that means for you is where we're going to start. Before we move on, Charles, maybe we can do one more poll. I just would love to get a pulse and see, maybe after our presentation or thinking a little bit more, how are you feeling about reporting for 2021? Where you need to be? Maybe there's some places you need to play catch up.
All right. Thank you, Brigid, for that wonderful overview and tips and tricks on how to make sure that people are ready. We've got the poll going here. We'll wait about 10 more seconds. It seems like we're split. Many people feel like they're ready. Some are not sure. And we've got some folks who are not participating because they're exempt. We have some APM participants and some folks who are doubting that they'll be ready. So thank you so much for sharing an honest look at this. It's anonymous, so we're not going to share your name. So it's important to just recognize where you're at and understand where you need to go. All right. Thank you, everyone. So please, we've reached the time in the session where we'd love to hear questions from all of you. We've got several questions that came in during the earlier parts of the presentation. So I want to dive into the first one here from Celine. And this question is, for the 90-day reporting period for IA and PI, are these the same 90-day periods or can they be unique to the category?
They are unique to the category. So your 90-day period for IA can be different than your 90-day period for PI. And I think I mentioned it, but they also don't have to be in a calendar quarter. It can be any consecutive 90 days throughout the year. And for the IA category, there are a few specific activities that require more than 90 days, but whatever time frame ends up working best for your practice is the right time frame. You don't have to do IA and PI in the same time.
Okay, very helpful. Thank you for that question, Celine. It's a great one. We have a question from Amy. How are incentive payments actually distributed?
Yeah, that's a great question. So incentive payments are assigned to the practice as part of your remittances. So when you receive a reimbursement from CMS, there's a line item that includes the positive or negative adjustment on that particular charge. So for example, for your 2021 reporting, although I hope this isn't the case, if you were to receive a 9% adjustment, when you submit a bill to CMS in 2023, you will see your regular reimbursement amount, and then you'll see a line item with that negative 9% adjustment, or hopefully positive, positive adjustment. So it's included as a line item for each and every remittance, and it happens 2 years after the program year. And is applied every time a remittance is issued throughout the payment year, which again is 2 years after the program year.
Okay, great question. If you have a follow-up, feel free to put that in. Thank you, Susan. All right. A great question from Becky here is, how detrimental is it to request the exclusion on the health information exchange?
Yeah, that's a great question. So in the PI category, in the health information exchange, which is also called HIE, there's HIE1 and HIE3, and then there's also HIE5 or 4. I have to go back and look at the slide. The answer to your question in short, Becky, is that it's not detrimental at all. Requesting an exclusion from the HIE measure requires that you have less than 100 patients in the denominator for both HIE1 and HIE3. There's also the option to request an exclusion from the entire PI category. That promoting interoperability category has really been a bear in the past. So CMS has a specific application process for practices where the PI category simply is not an option for them. Those would be instances like lack of control over CERT. For example, if you're a provider who sees patients in SNF units, the provider doesn't have any control over what systems your SNFs are using, that might be a reason to ask for an exception. The category of promoting interoperability has those exceptions built in, and then within the category, the specific measures, which is what Becky's asking about here with the HIE measure, there are also exclusions built in for the specific measure if it's just the measure that doesn't work for your practice. As far as I have seen over the years that I've been here and participated in this program, there has been no downside to requesting those exceptions. They're granted or not. Our consultants are very versed in that and can help you put together a application that is more likely to be granted. But if you receive that exception, you're not added to a list, you're not flagged, CMS is really encouraging of practices to use the exceptions when it's appropriate. That's why they created them. So if that is helpful for your practice, Becky, if that's really what you need to do, I would encourage you to take advantage of that.
All right, thank you for that question. Feel free to follow up if you need some additional guidance on that. In fact, we always do encourage folks to speak with us. All right, our next question is from Denise. We chose to measure for flu and pneumonia vaccine with COVID vaccines. We are seeing a low number getting, okay, sorry. We chose to measure for flu and pneumonia vaccines, but with the focus on COVID vaccines, we're seeing a low number of patients getting those vaccines. Can we add a measure at this point?
Hi, Denise. The short answer is yes, absolutely. You can add measures all the way up to the point of submission. As I kind of alluded to earlier, is the earlier you adopt a measure, the more opportunity you have to improve that measure. So that might be something to consider. You're not alone in that. With the emphasis on COVID, we are seeing just across healthcare a huge decrease in folks accessing the flu vaccine and the pneumonia vaccine. So it's not unexpected, but certainly if those measures aren't getting you the scores that you need to be successful this year, talk to your consultant about getting a different measure. You can also think about if there are ways that you could try to improve those particular measures. But again, with the time frame and with COVID going on, probably a different measure is going to be the way to go.
All right, well, thank you for that question. Our next question is a great question. It's a common one that we get as a qualified registry from Amy. What happens if you switch EMRs in the middle of the year? Can you combine data from the two systems?
Hi, Amy. Yeah, oh my gosh, this is the question, isn't it? So the short answer is yes. Yes, yes. There are, of course, some specific caveats in that if you have, if you end up not having access to data in one system, then we want to get that data while we can. I work with a lot of practices that are in this position. They change partway through the year. Maybe they're even operating on two systems for a specific amount of time. One thing I just want to call out is that for the PI category, although it's not impossible to do your time frame across two systems, it is really challenging. So for the PI category, I would recommend choosing a 90-day time frame that's just on one system. For the quality category, as a qualified registry, part of what we do is we take data from all kinds of sources and we get it to one submission. So data from EHR A and B is fine. Data from EHRA and a different type of data from EHRB is fine. We do a lot of that aggregation. So yes, absolutely. Changing EHRs is chaotic enough. So we are able to accept data from all kinds of sources and make that into a cohesive submission for you.
All right, but yes, great question. We deal with that complexity often, but it is one of our ninja skills of bringing data together from different systems as a qualified registry.
Absolutely.
So please do reach out, and we'd love to talk to you more about what you're dealing with. All right, so this is the last call for questions. One of our final questions here is from Denise. She's checked the QPP website and is looking for the final performance feedback report. And the screen, she can't find a screen that looks exactly like what we showed. As I understand it, that screen has changed slightly this year. So the picture we showed was from the prior year because it has pretty colors on it to really emphasize the different scoring components. Brigid, do you mind just commenting on where they'd find this and who to contact if they can't?
Yeah, absolutely. So when you are in qpp.cms.gov, you go to the upper right-hand corner and sign in. There's a multi-factor authentication process. If you don't have sign-in credentials, there's a contact number at the bottom of the screen that you can call, and CMS helps you set up with sign-in credentials. Once you're signed in, on the left-hand side of your screen, you'll see, I think it's called Reports. You click on that, and then you should navigate to Feedback Reports. You're welcome to call us at Mingle Health. We're happy to walk you through it. At the bottom of every screen in the QPP website is a 1-888 number that you can call and ask for help. That is CMS's resource, and they do a great job with navigating the website. They can walk you through click by click. They can see what you're seeing. So that's definitely where to start. Once you have those reports, if you have questions about what they mean and how they might apply to you, that's probably when a consultant can help you. So certainly try the help desk first. The phone number at the bottom of those websites, but you can always reach out to us if you're not getting what you need.
All right, great question though, because those feedback reports are chock full of useful information, as Brigid talked about earlier. So do take a moment to try to get your final feedback report from 2020, which CMS announced is updated and ready to view. So hopefully everyone gets a moment to find those. All right. Well, that is the end of our session here. I don't see anyone who took advantage of that last call for questions. So Brigid, I think we've made it through them all.
Great.
So with that, we want to just take a moment to say thank you to all of you for joining us today. Just a reminder that the slides and recording are going to be sent out by email later this week. And if you would like to talk about your organization to understand the best strategy for you, go ahead and jump on our website. Brigid and her team are the ones who are going to be answering the phone, answering your chat. They're here as a resource to all of you. So please reach out. We'd love to help you succeed with the quality payment program. With that, Brigid, I want to say thank you as well to you for sharing your knowledge with all of us for the last hour.
My pleasure. Thank you everyone for joining and listening.
All righty. Well, have a wonderful rest of your day, everyone. And thank you. And please be on the lookout for the recording and also an invitation to some of our upcoming webinars. Have a good day.